my name is Chris Smith. I'm an internist, also hospice and palliative care provider. I work for Northwell Health, which is a large health system in downstate New York. Originally from Long Island, so really enjoy the fact that I get to take care of patients in the communities where I grew up. Oh, absolutely. I'll tell you a story. When I was a second-year resident, I was sitting down with my program director, as we all did, to figure out what was next. Am I applying for fellowship? Am I, what am I going to do? And my residency director looked at me and he said, "So when are you going to, stop doing this home-based primary care research and, do something, more scholarly or real?" And I just looked at him and I can remember thinking, well, I'm pretty sure I'm in the right space. It may take a little bit of time, but we're gonna get there, and it's gonna be an exciting place to be. And so now, fast forward 15 years later, and I think we're there. And so the decision to stay in this space, I think, was a wise one. It's always a little bit of happy circumstance or luck. When I was trying to decide what to do with my life, I got introduced to several home-based primary care doctors at Mount Sinai, and this was before I was in medical school after college. And so I spent a couple days with Jeremy Bowl and the team at Mount Sinai, going and visiting patients in the home and meeting the providers who were doing this work. And at the end of those several days, I thought to myself, wow, if this is what medicine is all about, this respectful way of providing care with these just wonderful mission-driven clinicians, I thought to myself, I should go to medical school. And then I was fortunate over the subsequent years to stay in touch with the folks at Mount Sinai. And so I just kind of followed along with these great people, and I was just fortunate at the point where I finished my training that they had a job for me. So what makes me hopeful is that there is a need in this country and in our organizations to control total cost of care. And that total cost of care, particularly in our patient population, is really about unnecessary suffering. Unnecessary suffering of being in an emergency room, going to a hospital, getting readmitted. And so we are at this point where we have this alignment where the reduction in suffering that manifests itself in decreasing total cost of care is part of the national conversation. And I'm excited because the best way to reduce that suffering and reduce that total cost of care in our populations is to provide a good program. And so that alignment of, if we do the job right, our patients will have better outcomes and we'll create a financially sustainable model, is pretty exciting. There was a really seminal article in the New England Journal maybe a decade ago by Tom Lee, and it was, I think, titled something like "The Word That's Never Spoken" or "The Word That's Never Written." It's that patients don't suffer. We don't write the word suffering. But the reality of it is, when we talk about unnecessary utilization or low-value care or avoidable care, what we're really talking about is medical events that cause suffering. And we should just be really focused on that idea that we don't want our patients to suffer, and so we're going to eliminate the things that don't add value to their lives. What brings me joy is that every day I get out of bed and then I go to work to try and build programs that are aimed at vulnerable populations, and that the programs are aimed at the reduction in suffering of patients and families within these vulnerable populations. So I'm just very fortunate to be in a position where my job is about doing good in the world.